Dr. T.Thadhani, and I will be presenting with my colleague, Emily Phillips, on the second part. For the brief background, in 2021, the WHO TB guidelines released a conditional recommendation for computer-aided detection, or CAD, in the place of human readers for TB screening and triage among people aged 15 and above. So for CAD's performance, it's been found to be largely at par with radiologists. However, its accuracy may vary according to the population, which is why local calibration is necessary. So how does CAD work? A digital X-ray is obtained, and the image is then processed by the software. CAD then produces an abnormality score from 0 to 100, and a higher score indicates a higher likelihood of active TB. A heat map is also used to pinpoint lesions suggestive of TB. The set threshold score is then applied to the patient's CAD score to identify the patients who need confirmatory testing. So for example, if a participant undergoes chest X-ray and their CAD score is above the threshold, they are sent for gene expert testing. If their score is below threshold, no gene expert is done. For the rationale of the study, MSF wants to assess whether the implementation of CAD for screening is feasible in the challenging contexts in which we work. And if feasible, whether this X-ray with CAD could be integrated into broader algorithms for TB screening and triage. And this may also open up larger scale operational possibilities, such as using the mobile diagnostics for active case finding. For our study objectives, we want to describe the implementation of CAD for TB, including the calibration process and the cascade of care, as well as to assess its feasibility and its acceptability. So the study site is in Tondo, District 1 in Manila, Philippines. This is a high-density, low-income area, and a third of the population are extremely poor. Here, MSF conducts active case finding in the catchment areas of 4 local health centers. So we conducted a prospective description of programmatic activity using mixed methods. So for quantitative aspect, which is what I'll discuss, we studied participants 15 years old and above through TB symptom screening, chest X-ray coupled with CAD, and also gene expert testing for those with a CAD score above the threshold. The qualitative part, we interviewed healthcare workers who use CAD through individual interviews, and more details on this will be done later in the second part. For the calibration process, although some developers already provide a preset threshold of CAD, usually 50, it still requires calibration that selects the best threshold for your context. And so we selected the initial threshold through a pragmatic approach. We consulted experts and started from a lower threshold and did reactive adjustment. First, we looked at the expert positivity rate before we implemented CAD. We also looked at the testing capacity of the gene expert machine, as well as radiologist sensitivity and guidance. From here, we've decided that an initial score of 25 as a threshold would send around 35% of our patients for gene expert testing. After a few weeks, the threshold was then increased to 28. This resulted in a 34% gene expert referral rate, and that's compatible with our expert testing capacity. More on the qualitative aspect of the calibration process will be discussed later. So for an overview of the screening algorithm that we do, the participants undergo TB symptom screening as well as a digital X-ray with CAD. If they have no symptoms and their CAD score is below the threshold of 28, no further action is taken. If it is a positive symptom screen or below 28, or if their CAD score is above the threshold of 28, regardless of their symptom screen, they are sent for gene expert testing through sputum collection on site. Also, for those with a CAD score of above the threshold of 28, we also have a radiologist on site to review the film and, if needed, refer them to a medical doctor for further evaluation. If the expert is negative, there is no further action taken. However, for patients who test positive on gene expert, we refer them for TB treatment and household contact investigation. So here we have the mobile truck that we use, and this is equipped with a digital X-ray for our active case finding activities. And here we have a few participants lining up to be screened for TB, where we also have spot sputum collection on site to be sent for gene expert. So for the characteristics of the study population, from January to May 15th, the recruitment is still ongoing as these are preliminary results. We've screened a total of 4,853 participants. We've found that 15% have a past history of TB, and 13% were symptomatic on screening. For the results, we found that of the 4,800 screened, 34% had a CAD score above the threshold of 28. Thus, we've sent a total of 1,919 samples for gene expert testing. From here, 250 came back positive. This shows us a positivity rate of 5% among all patients screened, 13% among all patients tested, and 15% among all patients with a CAD score of 28 and above. For the expert positivity rate according to the CAD score, you'll notice that most of our sputum samples are actually for patients with CAD scores in the range of 28 to 39. But for the patients with CAD scores in the 80s to the 90s, the positivity rate is at 59 and 63% respectively. And although these lower CAD scores have lower expert positivity rates, had we used the preset threshold by the manufacturer of 50, we would have actually missed 35 cases, and this is 14% of all of our TB positive patients. So for our initial conclusions, we've found that in Tondo, Manila, active case finding has shown a high burden of TB, but CAD allows us to screen a high volume of people in a short amount of time. But we also need good data collection before the calibration process, and the expert testing capacity of your lab must be known to adjust the threshold. Also, reactive adjustment should be done regularly based on the local data collected. I'll pass it over to Emily for the second part.
So I'll be presenting a few of the key qualitative findings from the healthcare workers around the feasibility, acceptability, and practicality. So a really critical component of this implementation was piloting a pragmatic approach to calibrating the CAD software to the local context, particularly because the recommended calibration processes currently rely on access to large sets of X-rays, which just aren't available in most of the places we work. So the piloted calibration process really used a pragmatic mixed methods approach, drawing on both quantitative and qualitative data sources to ensure that the initial threshold set and subsequent adjustments were feasible, acceptable, and practical. So feasibility really had to take into account the gene expert capacity and the daily patient flow through the sites. And while this was a very quantitative calculation, it was supported by qualitative findings about the patient needs of this highly mobile population. As one staff member explained, the expert capacity is the most important thing because you need to be sure that you have a short turnaround time to get the results back to the patients before they move. Qualitative findings around user acceptability were also considered for the calibration process. As this was a pilot of CAD for MSF, it was new for everyone at every level of the project, including those coming out to train and support the team who were still learning about CAD capabilities during the process. This was described as initially generating a lot of stress and a lot of frustration because it takes time for the team to feel comfortable, and there are a lot of questions, a lot of things that were not clear. Additionally, while studies on CAD show no significant difference between the CAD and the radiologist reading overall, the case-by-case discrepancies in the field still impact user perceptions of CAD efficacy. As one of the team members reported, on a scale of 1 to 100, I have a confidence of 70 because there are some cases that are CAD negative, but I can clearly see there's something there and it shouldn't be negative. So taking user acceptability into account, the team decided to begin with the most conservative threshold that was feasible in order to maximize sensitivity. Simultaneously, they were supporting the team with hands-on in training in situ and collecting quantitative data on gene expert positivity rates alongside qualitative comparisons of CAD versus radiologist readings, particularly of X-rays just above or just below the threshold. This allowed the team to experience and become familiar with the results when they were relying on the CAD software, as well as to predict what changes in that threshold might do. Following this, reactive adjustments have been done based on the data collected and team discussions, and this process has really contributed to user acceptability. As one staff member stated, I think the current setup is doing okay, but let's see if there are going to be more discrepancies. Then maybe we should adjust the threshold. It really depends on the data we're getting. So alongside calibration, there were findings on the feasibility and acceptability of using CAD. The feasibility of using this software requires dedicated HR with technical capacity to support not just the CAD installation and the data management, but also the X-ray installation and maintenance and the truck specificities and logistics. A team member described that CAD has to have high-quality digital X-ray, and the same in the truck, which was a big problem and a lot of logistical challenges. So they needed HR with technical capacity to follow up on that, and that somebody should have been accountable from this from the very beginning. Additionally, to ensure that CAD is feasible for a TB screening project, users identified the need for good training and knowledge about the limitations intrinsic to the CAD software so that their personal practices and the project design in general could account for these limitations. For example, if we have pleural effusion, CAD won't read that. In that case, we still need a radiologist. It's not an error of the software, but it could cause problems in the circuit. So looking at acceptability regarding the actual hands-on use of CAD, all project team members found that it significantly increases capacity and reduces bottlenecks. The fast interpretation really helps to move people, to detect more patients, especially in a high-density population like in Tondo. Additionally, it was described as supporting decision-making across the whole team. As one team member described, even if you don't have much experience with TB, you'll see so much. So when you're making a clinical decision, it really is a very good assistance. So our preliminary findings are pointing to the potential for CAD to be a really powerful tool for TB screening, but that its success is also really dependent on careful planning and key considerations. First, a pragmatic and mixed methods calibration process can be effective, but has to carefully consider and balance feasibility, acceptability, and practicality. Second, dedicated HR with the required technical capacity throughout planning and implementation is critical. And finally, the intrinsic limitations of CAD must be well understood and accounted for in the project design. So just to quickly thank our study team, our project team, our local partners, and to point out Dr. Juno Min, who really led this calibration process. Thank you so much.